Dear participant, welcome to the 30th monthly webinar of the Afomp. Due to the COVID, we started this virtual monthly Afomp webinar in June 2020. And every month we are continuing this webinar with different topic, different speaker and different moderators. And this is the last webinar of this year because next month we have AOCMP. So December, I have not planned any webinar. So welcome to this 30th monthly webinar. And this is on biologically targeted radiotherapy, utilizing imaging biomarkers for precision radiation therapy and treatment response, a very important topic, and buzzword is a precision radiotherapy treatment. And today's speaker is Professor Annette Howorth from Sydney, Australia. Welcome, Professor Annette, for this Afomp webinar, and thanks for sparing time and accepting to be a speaker. Today's moderator is Dr. Aik Hao Ng from Malaysia. He will be moderating this webinar. He is a very well-known figure. However, I will try to introduce in brief. He is a senior lecturer in the Faculty of Medicine, University of Malaya, a medical physicist, a clinical oncology unit, University of Malaya Medical Center. He has a PhD in radiological and imaging sciences from UK. He's a member of Education and Training Committee of Afomp, very active into CFOM and Afomp, founder of the Ministry of Health and Physics Research Task Force. He also served as a physics advisory editor. With this short introduction, I welcome each one of the participants and requesting them that they mute their speakers and also put off the camera so you get a good bandwidth. This webinar is ACPSM CPD accredited with 2 points. A link will be provided into the chat box so that you can register and get the certificate. So welcome each one of you, and I hand over the floor to Dr. Aik Hao for continuing the further proceedings of this Afomp webinar. Welcome.
Thank you, Professor Chokli, for your kind introductions. Hi, everyone. Good morning, good afternoon, and good evening to everyone. Thanks for inviting me to moderate this webinar. And please allow me to welcome you all again to the 30th of Afomp monthly webinar organized by the Asia-Oceania Federations of Organizations for Medical Physics. And it is my great pleasure to present to you the speaker for today, Professor Annette Howorth from the University of Sydney, who will be sharing with us about biological targeted radiotherapy, utilizing imaging biomarker for precision radiotherapy and treatment response. So please allow me to share a little bit of Professor Howorth's biography. So Professor Howorth is a chair of medical physics, University of Sydney, Australia. And she is also the director of the Institute of Medical Physics, IMP. And she is also the course coordinator for the Master of Medical Physics. And she has vast experience, more than 25 years experience as hospital-based medical physicist who is specializing in radiotherapy and brachytherapy. So before we start these sessions, just a housekeeping notes. So it would be highly appreciated to take notes that this presentation contains unpublished data, and taking screen captures of the material in this presentation is not permitted. And also, please type your questions in the chat box, and the speaker will address the questions at the end of the talk. So without much ado, Professor Howorth, would you mind to share your screen?
How's that?
Excellent. So the floor is yours, Prof.
Okay, thank you very much indeed, and thank you for inviting me to give this this webinar. You've already had the introduction. So yes, I am the director of the Institute of Medical Physics at the University of Sydney, and also the course coordinator for the postgraduate medical physics program. So in Australia, if you want to be a certified medical physicist, you need to go through the master's program at one of the accredited universities, and we are one of the accredited universities. And like most academics, I do research, supervise PhD students, and lots of other things as well. But I've been at the university around 6 years now. And before that, I worked in a hospital. So I was a hospital-based medical physicist for more than 25 years. So yes, here I am in Australia. I am based at the University of Sydney in the School of Physics. Before that, I worked at the Peter MacCallum Cancer Centre, which is Australia's only public hospital dedicated to cancer treatments and research. And before that, I worked at Sir Charles Gardner Hospital in Perth, which is actually where I did all my medical physics training. So today we're going to be talking about biologically targeted radiation therapy. So what is biologically targeted radiation therapy? So if I'm going to be talking a lot about prostates today, but really a lot of what I'm talking about could be applied to any solid tumour that is suitable for radiation therapy. So in the case of prostates, we generally deliver a high dose of radiation to the entire prostate. But as I will show you in this presentation, we believe that we should be modulating the dose distribution through our target volume, and we should be targeting really high doses to where we find aggressive tumours. So in this case, we have a tumour down here bounded by a red line, and it has a really aggressive core. Maybe it's a hypoxic area that really requires a larger degree of radiation to sterilize the tumour compared to maybe the surrounding areas that have got a lower cell density, maybe that could have a lower dose of radiation for equal control of the tumour. So we want to know where we need to deliver high doses. And I'm also going to talk to you about quantitative imaging today to tell you how we can use this to work out exactly how much radiation we need to deliver. So the concept of biologically targeted treatments was first proposed way back in the year 2000. And it was an interesting concept at the time. It didn't really take off because at that time the imaging that we were using had low resolution, the quality was poor, it was expensive and not widely available and certainly not validated. But it was something that sat there with I suppose as a dream for everyone. But time's moved on, and that's what we're going to talk about today. So the essence of our work is really based on the fact that most tumours demonstrate tumour heterogeneity. And what that really means is that there's variation in cells throughout the tumour that demonstrate genomic and phenotypic heterogeneity. So this is an example of a lung cancer. So here's a tumour within the lung. And let's just say that this tumour consists of green cells, brown cells, blue cells and grey cells. But here in this case, I can tell you it's the blue cells that I'm worried about. And that's because the blue cells are apparently more aggressive, they're more likely to metastasize. So we still need to deliver some radiation to the brown cells and the green cells, but possibly we could get away with a lower dose because it's not such an aggressive tumour. So the blue cells will basically ultimately result in the demise of the patient. So what about if we really target our high doses of radiation at a much smaller volume, which could potentially spare other parts of the lung, the healthy tissue, and still achieve the same level of tumour control? So here's a tumour control probability equation. I won't go through all the details, but essentially it consists of a number of parameters which we need to know, which are based on the specific tumour biology. So for those of you involved in radiotherapy, you will understand that as we increase the radiation dose, the probability of tumour control goes up. But also if we increase the dose, the probability of complications increases as well. So what we're really interested in doing is just finding that sweet spot, that level of tumour control probability that is maximised whilst also minimising the probability of complications. Now, our work is very much based on a voxel-wise analysis. So basically, I've got an image here which has got lots of boxes with each box representing a voxel. So the idea of this tumour control probability equation is to take each voxel I, work out what the specific tumour characteristics are in that box, and then for a given dose D, we can calculate what the tumour control probability will be. So in other words, we want to reach that level there and increase the level of dose D until we reach this threshold value. So let's go back to the beginning then. So my research team are working on a project which we call the BIRT project, with BIRT standing for Biologically Targeted Radiation Therapy. And in the presentation today, I'll be talking about various stages of the patient's journey as they have radiation therapy using biologically targeted radiation therapy. So we have a new patient. They will undergo quantitative imaging. So in a moment, we'll have a look to see what that is. We'll then look at how we deliver a treatment plan with the biofocused approach. And then we'll look at how we can use imaging to monitor the patient's response to treatment. So I'm going to talk about prostate cancer. As I said, we've actually done a lot of work in that area. So I've got lots of images and lots of work that I can show you, but we are working on other tumours as well. And I'll mention that briefly at the end of the presentation. So you will know that the prostate sits deep in the pelvis. It's surrounded by the bladder and also the rectum. So it sits there surrounded by organs at risk, with the urethra passing through the prostate. And again, damage to each of these organs at risk will result in toxicity when we're delivering our radiation. So standard radiation with external beam radiotherapy brings radiation beams from lots of different directions. So this is the prostate deep in the pelvis. We normally aim to deliver a high dose of radiation to the entire prostate, but the organs at risk will receive some radiation. In this case, we've got the rectum here below the prostate. So let's think a bit about what are the issues, what are the questions that we need to answer with prostate cancer. So these are Australian statistics, but essentially this is replicated around the world, of course. So we do have a lot of men diagnosed with prostate cancer. So Australia's got a population of around 25 million people. So in 2018, there were nearly 18,000 men diagnosed with prostate cancer. So it's certainly a big problem. And the 5-year tumour control rates actually are very good. So 95% is what we reported in 2018, which is up from less than 60% in 1988. So we're doing really well. However, 5 years is actually very early to measure the response of any treatment with prostate cancer. It can be a slowly progressing disease. Ultimately, there are still a lot of men that do die from prostate cancer. So ultimately, around 30 to 50% of patients will fail treatment, either due to local resistance to the radiation therapy, or they can result in systematic spread. But what we do know from previous studies is that if we increase the dose of radiation to the tumour, we can increase the tumour control rates. But of course, increasing the radiation dose will result in an increase in side effects or toxicity. So our question is, how can we increase the radiation dose without increasing toxicity? So with the prostate, then we do currently treat the entire prostate gland. Now, historically, the reason for that is because it's not actually easy for us to accurately visualize where the tumor is inside the prostate. But in actual fact, with the emergence of the use of MRI and also PET, there are now ways where we can identify the location of the prostate. So this is a T2 weighted MRI and an ADC map. So you can see they're blurry images, but you can see there's something going on inside. So yes, we can now actually see where the tumor is. And so this was a study that was conducted by the Dutch group called the FLAME study. and it was published last year. And they run a clinical trial where they randomized patients to receive a boost dose of radiation to the tumor compared to patients that received the standard dose of radiation to the entire prostate. So it was either the entire prostate or the entire prostate plus a boost dose of radiation. And what they found was at 5 years, the disease-free survival rates were 92% in the boost arm compared to 85% in the standard radiotherapy arm. So this works. But if we look at the toxicity rates, you'll see that the greater than or equal to a grade 2 genitourinary toxicity and the gastrointestinal toxicity are still reasonably high. So that tells us that really we've probably reached the threshold in how much radiation dose that we can deliver using this type of approach. So if we take the FLAME study one step further, let's have a look at how they did this. So they used the MRI images similar to what I showed in the earlier slide, and they're certainly blurry images. So if you take a whole bunch of clinicians and ask them to delineate where the tumour is, you'll come up with very different volumes. The important thing to also understand is that they, in the trial, they aimed to deliver 95 Gray to the tumour, whilst maintaining the dose constraints to the rectum and the bladder. And in most cases, they weren't actually able to achieve that 95 Gray. It was actually 85 Gray. So that was the median dose that was delivered to these patients. So they set out to deliver this really high dose of radiation to the tumour, but they weren't actually able to achieve it in many cases. So as a result of the FLAME study, we can say then, how can we move forward? So could we formulate an objective rather than a subjective way of delineating the tumour on our MRI? And also, can we determine the optimal radiation dose that we need to deliver? So first of all, to the tumour volume, or the GTV, and the rest of the prostate, or the CTV. So prostate cancer is a multifocal disease, so we need to still treat the rest of the prostate to make sure we take care of any smaller volumes of tumour that we might find there. But really what we're aiming to deliver is a high dose of radiation to the GTV. So introducing the concept of quantitative imaging, you're all probably using quantitative imaging every day anyway. So with radiotherapy treatment planning, for example, we look at the CT number and we relate that to electron density to do our dose calculations. Similarly, for those of you involved with PET imaging, we typically use SUV to define where our tumour volumes are and other things as well. And with MRI, we can do multiparametric MRI. We can produce different images which will tell us different things about the tumour. So diffusion weighted imaging, for example, what we can do is we can produce things called ADC maps, or apparent diffusion coefficient maps, which tell us something about the cellularity of the tissue that we're imaging. And dynamic contrast enhanced imaging, or DCE, will enable us to do kinetic modelling. So DCE involves the injection of a contrast agent, and I'll talk more about that in a moment. So each of these imaging modalities will tell us something different about the particular tissue that we're imaging. So obviously I'm interested in cancer, but here I'm actually interested in more than whether it's tumour or not tumour. I'm actually interested in knowing something more about it. So K-trans will tell us something about the perfusion. Hypoxia will tell us, BOLD will tell us something about hypoxia. Diffusion weighted imaging will tell us something about cell density, cellularity and proliferation. And PET imaging will tell us something about the metabolism. So talking about DCE, I won't go through all the details of this, but just for those of you not familiar with DCE imaging, essentially the patient is injected with a contrast agent. The contrast enters the tumour with some kinetics, some level of kinetics, so the rate of the contrast agent entering the tumour. It will then stay there for a little while, and then it's what we call washout. The contrast agent will leave the tumour. And by modelling these kinetics in different ways, we can come up with different parametric maps. So this is where we've taken on a voxel-wise basis the different parameters that we can extract from the DCE, which tells us something different about the tumour and how it behaves. So when it comes to contouring, then there's all these different maps that we can produce. Obviously, this is a head and neck case, not a prostate, but essentially what it will tell us is that if you try to delineate the tumour on these different maps, you'll come up with very different volumes. And the reason for that is each of these maps will produce different volumes because they're measuring different things. So what do we use in radiotherapy? So with biologically targeted radiation therapy, then remember I was going to tell you where we need to deliver high doses of radiation and how we're going to use quantitative imaging. But what I'm going to tell you is it's not really so much about putting a red line around a tumour. It's about thinking of each individual voxel and what's going on in that voxel and how much radiation we need to deliver in that voxel. So there's a certain concept of delineating the tumour which is not totally relevant in what it is that we're trying to do. So I'll just say that again. So our interest is not so much in defining the boundary of the tumour. Instead, what we want to do is describe the distribution of the tumour biology. In other words, we want to describe the blue cells, the brown cells and the green cells so that we can predict which are the ones that are really going to cause us some trouble down the track. So we've been building imaging biomarkers. So what are imaging biomarkers? Imaging biomarkers are basically predictive models. In our case, these predictive models are going to tell us something about the tumour. Well, we do want to know where the tumour is, of course, make sure we're targeting the radiation in the right area, but we're really after the tumour characteristics. So how can we build a predictive model? So we've been doing this using machine learning techniques. So, for a patient cohort, we had imaging. We had some imaging on a whole bunch of patients. Now, these particular patients that were recruited to our study were actually scheduled for surgery. So they were going to have their prostates removed. And this enabled us with ground truth information. So what we did is we did basically a correlation between each voxel within the histology and the different features that we can extract from imaging to enable us to build this predictive model using machine learning techniques. So just breaking that down a little bit further. So these are all the different types of imaging and the imaging maps that we produce. There was a lot more than that. But basically, we took each of these images that were done before the patients had their prostates removed. We removed the prostates, we sectioned them, and then what we did is we correlated it all into a single space, a co-registration space, so that we could derive the correlations between the features in our images and the ground truth histology. So, so we first of all developed our predictive models just based on the MRI imaging. That was what we had mostly in our cohort of 70 patients. And we had a PhD student at the time, who's now long graduated, his son, and he did develop models that were able to predict tumour location, cell density, and also tumour grade. And these are all important things that we need to know when we're doing biologically targeted radiation therapy. So the next part then was, well, we did have some PSMA PET images for some of our patients. So PET imaging, I'm sure you all know, is positron emission tomography. In the case of prostates, the one that is of most relevance is prostate-specific membrane antigen, or PSMA. Now, this is now commonly used in Australia. I think we were probably one of the leading countries in doing this. For some reason, it just seemed to get off the ground. There was a lot of excitement and enthusiasm from our clinicians, and we managed to get it through a lot of the approval processes that a lot of other countries have struggled with. So we were lucky. Now, this was a cohort that was collected or recruited a few years ago now, so we didn't have PET in all of our patients, but we did have enough that we could have a look to see whether there would be any benefit in adding the PET to our modelling. So this was one of our master's students. And so he did his project looking at adding the PET to MRI, and you can see in looking at the sensitivity and specificity that there was some value in adding the PET and MRI. Now, it doesn't seem to be a great deal of value, but I have to say that we've got a lot more data on the MRI. We had 70 patients, but with the PET, we only had around 20 patients data. So there's still a lot more work for us to do in this area, but it does look that like PET can actually improve our predictive models. And again, this is just another picture showing his work. So again, I'm sharing with you today a lot of our work that is in the process of being written up for publication. And so this is certainly one of the papers that is in progress at the moment. So this is sort of what a PSMA PET looks like. You see a great big blob. This is what the MRI looks like. So the white is where we have predicted the tumor location, and the color is coming from the annotations. So we had pathologists annotate the tumor, and we correlated that with the position on the PET and the MRI images. So we've got pretty good correlation here. Okay, now let's go back to our tumor control probability equation. So as I said to you before, this is the equation, and we need to define a number of parameters within this equation that describe the tumor biology. So we want to do this for the specific patient. We don't want to just take numbers from the literature. We want to be able to look at our individual patient. So where can we get these values on a voxel-wise basis? So I've already talked to you about some of these parameters, but what I'm going to talk to you now is about hypoxia. So hypoxia in prostate cancer has been shown to predict biochemical failure. So hypoxia basically means that it is devoid of oxygen. So you basically need oxygen within your cells in order for it to respond to the radiation. So if a tumor is hypoxic, or it's got hypoxic regions within it, then that we know that that tumor has a higher potential to metastasize. We also know that it has a higher resistance to radiation therapy. So in other words, we need to deliver more radiation dose to our hypoxic regions within our tumor. But this is not really terribly well understood in prostate cancer. And part of that is it's very difficult, or historically it's been difficult to visualize hypoxic volumes in 3D space. So perhaps we could just move that. So although there have been probes which have been able to measure it, it doesn't give you the spatial distribution that we need for radiotherapy. So we ran a study whereby, I should say that one of the problems with hypoxia is you can't actually see it in a normal histology stain. We had to look at alternative methods of defining hypoxia for our ground truth for our predictive modeling. So what we did was we took our tissue specimens, we took some punch biopsies, and then we did some genetic profiling on these biopsies. So what we know is that there are some signatures, which basically mean a whole bunch of genes that have been demonstrated to correlate with hypoxia. So in other words, if we took one of our punch biopsies and we found the expression of these genes, then that would suggest that that's got hypoxia. So then we could look for signals within our multiparametric MRI that would correlate with these signatures of hypoxia. And then this is still early work. It does obviously cost a lot of money to do genetic profiling, but we were able to find 16 features within our multiparametric MRI, which show promise for future correlation. So we're hoping to extend this work in the future so we can build our predictive model. Okay, so I've talked about quantitative imaging. So now what I'm going to do is talk about how we now can take our quantitative imaging and produce a radiation dose distribution so that we can then deliver using our treatment modality, which in this case is a linear accelerator, but equally it could be delivered with brachytherapy or even particle therapy. So we wouldn't normally recommend particle therapy for prostate cancer, but let's say, for example, you have got a hypoxic region, maybe you need to deliver even more radiation that you can currently deliver with photons. So this is Emily, who is one of our PhD students, and Emily's produced a number of papers, but I'll refer you to this paper, which is a review paper that we published in Cancers in April 2020. So Emily demonstrated that by taking quantitative imaging, we could translate that into a tumor biology distribution, and with that we could then plan a radiation dose distribution which we could then deliver with our machines. So I won't spend a lot of time on this today because it has been published, but essentially I'll just go through the highlights of one of her papers. So in one of her first papers, she compared a conventional radiation dose distribution using IMRT, 78 gray into gray fractions. She then produced a plan where instead of using the anatomy, which is what we usually do to derive our dose distribution, she used a biological optimization approach. She then considered the fact that we're producing very small beamlets, in other words, a highly modulated dose distribution. And we know that patients' position can vary on a day-to-day basis, and they can breathe and do all sorts of things. So we needed to make sure that our model was robust. So she incorporated in Plan C prostate motion to account for the delivery uncertainty. So Plan A, this was the standard radiation dose distribution. So she just basically took, well, she had a bunch of patients, but she took patients and she calculated the tumor control probability based on the dose distribution that had been formulated using conventional treatment planning approach. And the TCP value came out to be 0.61. So again, just a reminder that when you're doing radiobiological modeling, as we are, a tumor control probability, it's really a relative measure. It's not suggesting that 61% of patients will have this tumor control, or this patient will have a 61% chance of tumor control. It just means that this is a value, and if we do another similar plan, we can judge whether it's better or worse. So she then did the biological optimization, and she was able to show that by using this approach, the tumor control probability was greatly increased. But then she introduced what I call the wobble, in other words, the uncertainty in the prostate position due to day-to-day variations in the treatment in the prostate position. And then she was able to produce a robust plan that increased the tumor control probability to 0.84. So not quite as good as one with no uncertainty, but basically it demonstrates you do need to take into account this uncertainty. So in other words, for biologically targeted radiation therapy, we need to be mindful that we are producing a highly modulated dose distribution, and to precisely deliver this highly modulated dose distribution, you do need to be able to deliver with a high degree of accuracy. So I'm not suggesting that you need an MR-Linac, but certainly you do need other things to consider, such as fiducial markers or tracking of fiducial markers, but you also need to be able to well define your target volumes, including your organs at risk. So now I would like to move to the next part, which is looking at using imaging to follow our patients after they have had radiation. So we've done all this imaging here. So why don't we repeat the imaging at certain time points after they've had treatment to see whether they have responded to the radiation. So we're thinking here again about the biology. So what will that tell us is how has the biology changed after radiation has been delivered? So the question was then, can quantitative imaging be used for response assessment? So remember, we're talking about multiparametric MRI. We're also talking about PET as well, but let's just look at that for the moment. So if we are able to detect treatment response and find an early lack of response, then we can either adapt the radiation therapy if we can pick it up during the time of radiation, or we can pick it up after treatment and offer salvage therapy. So we know the earlier we go in with a salvage therapy, the better the chance of cure. So with prostate cancer, this is typically what happens. So if a patient has had external beam radiotherapy or brachytherapy or a combination of both, what will happen routinely is that they will have a blood test, which is called prostate-specific antigen. So this measures the level of prostate-specific antigen, and it's a marker of tumour. And typically what will happen is the PSA level will drop down after radiation therapy. So this low point, or the nadir, typically occurs 12 to 18 months after radiation therapy. But at some point in time, it's possible that that PSA level will go up. Now, the reason why it goes up, it could be for a number of reasons. It could be because the tumour has recurred, it's growing again. Or it could be due to other things. It could be even an infection in the prostate. It could be multiple things. But so what we do is we make sure that we continuously measure the PSA at multiple time points until we really feel confident that the patient really has failed. And then we offer treatment, at which point it might be too late. Maybe the disease has already metastasized. So, so in other words, PSA blood test then lacks specificity, so you can get a high false positive rate. It can't discriminate between local and distant failure, and it can take a long time to identify that failure. So what we'd be interested in doing is monitoring at certain time points, which is yet to be determined, to see whether we can determine early whether the patient is going to fail later on in time. So now I'd like to introduce you to Erin, who has been our PhD student for the last few years. Actually, Erin has just completed her PhD, and I'm going to present some of her work, which she is madly writing up for publication at the moment. So what we did was we ran 2 clinical trials. The first trial we called CBIRT-1. So CBIRT stands for sequential imaging after biologically targeted radiation therapy. Now, these patients actually had standard radiotherapy, but what we want to do is apply it to our biologically targeted radiotherapy approach. So this is sequential imaging. We recruited 30 patients, first of all, that had radiation therapy, and we did imaging at 6, 12 and 18 months after radiation therapy. So that's our CBIRT-1 study, and I'll present some of the results of that study. We then did another study where we recruited 10 patients. Now, with these patients, we imaged them at 2 time points before radiation therapy, and I'll explain why in a moment. And then we image them again during radiation therapy. So at this point, we're exploring the possibility of doing adaptive radiotherapy. So what Erin first really needed to do was she wanted to work out what was the uncertainty in these measurements. So if we measure a particular parameter, maybe it's ADC, maybe it's K-trans, at some point prior to treatment, then let's say that signal goes up and then goes up again, but there's some uncertainty involved in that. So what we want to know is that a true treatment response to treatment, or is it just due to the uncertainty in the signal? So we needed to basically go through each of these parameters and work out what were the error bars, so then we could determine what was the threshold that would determine whether we've actually got a response to treatment or not. So in other words, if the uncertainty in the measurement exceeds the change in signal, it's not a reliable biomarker. So Erin basically had 3 aims for her PhD project. The first was to identify scanner-related uncertainties. So this was just doing phantom studies. So she repeated the studies over a long period of time. She also wanted to know what the variation was in an individual patient. So if you scan them, get them off the scanner, get them back on again, maybe come back a few days later and scan them again, what changes would happen there. And then she wanted to identify parameters as a result of irradiation. So with her first aim, she imaged the phantom. She had a commercial phantom, and she also had an in-house built phantom. Now, the reason why she did this was this commercial phantom, we had one that we had to share between 3 different sites that were participating in our study. What we wanted them to have was their own in-house phantom at the local site, so that they could do more frequent measurements, and if necessary, we could run out with the commercial phantom. But we did the commercial phantom every 6 months, and this one was done more frequently. So the results of this study are published, and the results were, are our scanners stable? Were they stable during the clinical trial? And the answer was yes. In fact, in determining the measurement of each of these parameters, we found there was a less than 2% variation in most of the parameters that we measured. Also, when we compared the data across the different scanners, we found that there was little difference between them. So we were able to pool all of the data. Then looking at the second study, we wanted to see whether there was patient-related variation. So we had some healthy volunteers, and we also included our patients from the CBIRT-2 study prior to their radiation therapy. And what we found was that the threshold depends on the parameter being measured, and also where in the prostate it's being measured. So for example, in the posterior part of the prostate, which sits adjacent to the rectum, you can get artifacts from gas, for example, which make it less reliable. Also, she looked at a region of interest and a voxel-wise analysis, and I won't go into the details of that, but essentially voxel-wise is very challenging to do, but it gives us lots of information, and we are particularly interested in tumour heterogeneity, so that's what we wanted to do. But what we found was it does require very accurate co-registration of the images to produce reliable information. So what she wanted to know then was, can we locate areas of the recurrence? So again, this one is up for publication, and so I'm just giving you a sneak preview of some of the results. So I'll just talk you through this image. So remember, we imaged the patients prior to radiotherapy, and we have the tumour location identified here in yellow. We then image them at 6 months and at 12 months after radiotherapy. So this is our T2-weighted imaging, which is good for anatomy, but these are just two of the parameters that we looked at. So we had several parameters that we investigated. So our ADC values, that's what the MR looks like. And here is our model. So what we were able to show was that parts of the tumour appear to be responding to radiation, or they change significantly. In other words, it was above that threshold for change. That's the dark brown area. And with the K-trans, it's the dark green area. So there's still some parts of that tumour there that doesn't seem to have changed very much from when it was first imaged. Now at 12 months, this seems to be getting larger, but there's still some areas of the tumour which don't seem to have responded. But with the K-trans, that seemed to give us more reliable information on detecting that change. But there's still areas here where you could say, has that actually responded to radiation? But the message that we want to deliver here really is each of the imaging parameters gives us different information. And when we pool all the information together, that will give us a more reliable indicator of whether we need to be concerned or not. So Erin's PhD conclusions were then that quantitative MRI shows promise for monitoring treatment response, but the thresholds need to be established to account for measurement uncertainties. The analysis is complex, and I haven't had a chance to talk about this, but some of our patients had hormonal therapy, and we found that we need to analyse those separately. The thresholds are different. And also when you're analysing the data using either a region of interest or a voxel-wise analysis, again, the results need to be considered based on your approach for the analysis. But the main conclusion really is that each parameter tells us something different about the biology and the physiology of the disease. We are still to determine the optimal time point for measurement, so we're still analysing some of the data. But what we do know is that combining the parameters is needed, and watch out for our manuscripts, which we hope will come out over the next few months. So as I said, I haven't had much time to talk about other cancers today, but I did want to let you know that we are working with liver cancer, and we have a trial which is just about to open. We're currently analysing some data from a breast trial, and we're also looking at developing radiomic studies for colorectal cancer. So in summary, with biologically targeted radiation therapy, we are able to determine where high doses of radiation should be delivered, and we can also determine how much radiation should be delivered. But imaging biomarkers may be the future of accurate prediction of treatment response, but there's still more work to do. So the models that I've shown you today do need validation in multi-center studies, and also, of course, they do need to come with them precision in treatment delivery. So if you're interested, in finding more about our work, you can visit our website, which is here up on the screen. And I'd just like to thank the many people that have been involved in our studies. Thank you very much.
Thank you, Professor Howorth. That's wonderful and very informative presentations. So I think we learned more about the use of this biological targeted radiotherapy technology and how it can be quantified and make this treatment more accurately. I think ultimately, we as a healthcare professionals, we would like to save more on the organ areas, and of course, to optimize the target dose to these target regions. And okay, so I think we have received a few questions from the chat box. Prof. Howorth, yes, I'm going to share my screen now. Right.
The wobble technique. Yeah, that's my little terminology that I used here. So obviously when we put the patient on the couch every day,
Right.
we image the patient, right? Now there's different ways of imaging the patient. So, you know, you might have cone beam CT, or you might have fiducial markers, and you know that's pretty good, and we can get it pretty much right, but there's still some uncertainty, there's some deformation, and of course we do know that even once you've set the patient up, you can leave the room and the patient might have a little wriggle on the couch. Okay, so we need to remember that, you know, we're trying to deliver radiation with, you know, these voxels, you know, each dose that we deliver in each voxel varies, and so, you know, patient only needs to move 1 millimeter to the left and you've got a very different dose distribution, so it's not going to work. So
Right.
essentially what we needed to do is we needed to incorporate that uncertainty in the prostate position, you know, in our treatment plan. So it's like robust planning. It's a little bit like proton therapy, where you may have heard of doing robust treatment planning. So essentially that was really what we were talking about. So yes, we do cone beam CT to set up our patients, or fiducial markers, or a combination of both. There are also methods to monitor the patient during treatment, again, typically using fiducial markers, and there's some research being done, not in my group, but in another University of Sydney, where they are also doing markerless tracking, again, using machine learning or deep learning methods for doing tumour tracking. Of course, I've talked about a LINAC. We've still got the CyberKnife. We've got other, you know, lots of other different treatment modalities. Brachytherapy is perfect for this type of treatment, because we know where our catheters are, so we can deliver the radiation quite accurately using brachytherapy. So yes, so I basically just wanted to explain that, you know, you do need to take into account, you know, what are the uncertainties in your treatment position very carefully with this approach.
Yeah, I think that's very important in our daily job, right? So I think there is a second question. Can you see this, the slide from Fumiyuki Miki? So she asked about, please tell me what is a rectal spacer made of?
Yeah, so I didn't talk about rectal spacers, but essentially you can use a rectal spacer which is made of hydrogel. So it's basically something that can be injected in the space between the prostate and the rectum, and so it provides a bit of space, so that you know the intention is obviously to reduce the dose on the rectum, to reduce the side effects from treatment. So this again is quite commonly used in Australia now. Over a period of time, the hydrogel dissolves. It does show up as a bright light on the MRI. So again, that can actually give you some more artifacts as well. But again, there are different ways that you can manage that.
Yeah, absolutely. I think, Mickey, you can look for more publications in the recent journals. There are some good journals that shows about the utilizing of these techniques to reduce the dose to the rectal. And from Zukora, he asked about which contour volume of GTV from different modality is correct for dose delivery. I mean, I think maybe for PET CT, for example, which one actually we choose?
Yeah. Well, in my presentation, what I was trying to explain was that actually we don't really use the concept of a GTV, because what we're doing is we're considering each voxel individually. And so you're thinking it more of, you know, what is your distribution of cell density? You're not really thinking of it as actually delineating a GTV. Now, again, I didn't go into so much detail, but obviously we do have algorithms where we do delineate around the tumour. And one of the reasons why we're doing that is when you're doing radiomics analysis, usually what you want to do is essentially cone down on where the tumour is and only consider the features that are within the tumour region. Otherwise, you would have massive amounts of data and it would take you, you know, a long time to do the calculations. But essentially, our approach is not to specifically use a GTV. Our approach is to consider on each voxel, what radiation dose you need to deliver. So if you've got a very low risk of finding a tumour there, then potentially you could get away with a lower dose of radiation. But if there's a higher risk of finding tumour there, then obviously you want a higher dose. But then you want to know how aggressive that tumour is. So it's very aggressive, it's hypoxic, then you take the dose up even further. So there is no GTV as such.
Just echo to these questions, Prof. For example, for PET-CT quantification, when they want to draw about this MTV, the molecular target volume, so there are different methods, for example, SUV max or different kind of like contouring techniques. So in your center, would you mind to share with us your experience in this?
Yeah, so essentially, so obviously I'm based at the university and I work with lots of different centres, but I was actually talking to one particular centre today and we were going through their process. So I'll share with you one centre just to make the answer a little bit easier. So what they do, they're a great believer in PET. They've been using PET for a very long time. So the first thing they'll do is they'll look at the PET and go, okay, we can see where the tumour is. Then they will look at the MRI, but they will actually use the MRI to delineate where the tumour is, and they will deliver their boost dose to the MRI delineated tumour. So in other words, when they look at MRI first, you see this sort of fuzzy black image and go, oh, I'm not quite sure where the tumour is. So the first thing they do is they look at the PET and they go, okay, this is really clear. We know the tumour is over here. But PET is just, big bright blob. You can get obviously some flow from, if it's gone into the bladder, and it can be misleading. It can, it can actually give you false information in some cases. So the reliable information is the MRI. So they delineate the tumour volume. This is like the FLAME study, if you like. So they draw a volume based on the MRI, but they're using the PET to guide it. So they're not using an SUV level as such. So I'm not going to say it's 60% or 40%. I'm not going to say that. I'm saying PET is useful as such, shall we say, a qualitative indication of where the tumour is. It gives you confidence in using the MRI. Now, obviously, I presented all of our research work today. If you now want to go to the literature, what you can do is you can refer to the PIRADS guidelines. The PIRADS do give you guidelines on determining where the tumour is. So, for example, it will tell you what a threshold of an ADC value is that you can use for delineating the tumour volume. Now, that's a guide, and it is only a guide because an ADC value will actually depend on how you derive your ADC. So ADC stands for apparent diffusion coefficient, and it's made up of doing a linear fit on an exponential curve from different B values, which I won't go through all the details of that, but essentially you can come up with different ADC values depending on how you do your curve fit. So it's not reliable by itself, but it's a good starting point.
Thank you. And our next participant, Debolina, she's asking about any specific software used in TPS for planning. Probably, yes, just to share your center experience.
Yeah, so obviously, again, our work is experimental. It's very much in the research domain, what I presented today. So when I showed you Emily's work, for example, her treatment planning, she was using MATRAD, which is an open source software package. Now, even that is not specifically designed for what we're trying to do. But it did enable her to do the optimization. So essentially what we have done in the research domain is we produce what we would call an ideal dose distribution, and we essentially create structures based on different isodose levels, and then we put that into a treatment planning system. And we're doing a study at the moment where we've got multiple different planning systems. We've got Eclipse, we've got the planning system associated with CyberKnife, we've got the planning system associated with the Variant Ethos machine, so a whole bunch of, and Protons as well. So they're all different planning computers that we're using, but essentially we're starting with the same starting point, and we're calling that a dose prescription. We're saying this is what we want the dose to look like, now optimized based on this ideal dose distribution, which is basically defined as a series of structures. So you're all probably used to doing a head and neck treatment where you say, well, I want so much dose to this first volume and so much dose to the second volume and so much dose to the third volume. And that's basically how we're doing it as a workaround. But obviously we're hoping that this will be integrated into treatment planning systems in the future that will enable you to do treatment planning as you do today, but doing it based off your map of biology rather than your map of anatomy.
Thank you. I think these will be the last questions for today's. May I know more about the development of this predictive model that you showed just now? You mentioned about the use of MRI images and PSMA PET. Are these streams that use only single center data, or how about the reliability of these used in the clinic so far?
Yes, that's a very, very good question. So that is true that the model was developed based on that data set that you have there in the question, and we have published that work, which we have validated. So essentially what you do is you take aside a training data set and you hold back a certain amount of data, which you can then test it on and validate it. Now, having said that, what we're then doing is we've now got the other data sets that we've used with our sequential imaging projects. So we can now use those models and apply those to different data sets. And the problem with those, of course, is you don't have ground truth. The ground truth is the histology. Okay, so it is very difficult to validate it. But one of the difficulties that you have in developing these models is that it does rely on how you've acquired the images. So what we're wanting to do with our work is to actually encourage centres to use standardised forms of imaging. And I'll say right from the outset, what we have always used is imaging protocols, which are based on the PIRADS reporting system. They're recommended in the EUSR guidelines for imaging. And we hope that essentially we'll be able to develop consensus guidelines on imaging, which means then that we can take data from different centres, which we can then go forward and further validate the models. And really that was part of the reason why in my conclusion slide I said these models do need to be further validated in the multi-centre environment.
Wonderful. So I think that concludes for these talks today. And I think Prof. Howorth have shown us about the excellent research works, which has been a very good results and also applies in the clinics as well. And she also showed us on how the medical physicists can extend our work's collaborations with other colleagues, for example, biologists and other as well. So without further ado, let's join me to thank Prof. Howorth as usual. And thank you very much, Prof, for giving this wonderful talk.
You're very welcome, and thank you very much for inviting me.
Thank you. And as we are, thank you. And over to you, Prof. Jugli.
Yeah, thank you, Aik, for excellently moderating this very important the webinar, Afomp webinar. And as you said, I have witnessed being in Sydney University with Prof. Annette and also listening to a lot of project of her students and also the progress going on. The excellent work, and that is multi-department involving work, as you said, clinically radiobiologists and the clinicians involving, and how we can make it a precise, personalized radiotherapy, and that in that direction, this basic researches are very, very important. And thanks to Professor Annette for sharing her work and giving this wonderful talk for all of us. To add on few things, yes, the GTV and all, when you are individually demarcating, there will be slight variation. But I think now AI can help you or auto counting, auto things, and the pixel to pixel. When you have got the hybrid imaging, the fusion imaging molecular. Unfortunately, we do not have very good tumor biomarkers, but the medical imaging in terms of MRI, PET, from just not only anatomical, but the molecular and functional, is helping a lot in delineating the OAR and the tumor, and then escalating the dose and getting very, very good results. So thanks once again to all of you. And let me remind that we have AOCMP 2022 being organized in Taipei, and now there is no quarantine required if you are coming and joining in person. Also, the organizers have made it can be in a hybrid mode. You can join virtually also. So please take advantage of this wonderful annual meeting of the Afomp 22nd Asia Oceania Congress being held in Taipei during 10 to 12. Similarly, on 7th November, we are celebrating International Day of Medical Physics, and this year's theme is Medical Physics for Sustainable Healthcare, very important, and a lot of programs have been arranged, and there is a IOMP webinar also. You can visit to the IOMP website and join to this activity. Once again, thank Professor Aik Hao, Professor Annette, Professor Chai Hong, Rajini Verma, and each one, the Professor Anupama, all delegates for making this happen. And continuously since June 2020, we are doing this Afomp webinar in addition to Afomp school of 2 to 3 hours. So thank you very much for sparing time and getting involved into this thing. Have a nice time.
Thank you. Bye-bye.
Thank you. Bye.